Hello, guys. So, I am about to do your first part of your stroke video. I've already filmed this video one time and it didn't really work out well, so here we go again. But I'm going to try to make this a little bit quicker than the last one so you don't have a 45-minute video to watch, plus the other one that I recorded. Really quickly, though, I do want to say I'm not doing a MedMath review because nobody seemed to really want it. And I know Dr. Schneider did a review, so I think that that's definitely sufficient for you guys. And I think that if you guys use that and you do the practice exam that he posted, you'll be completely fine. But if you guys have any questions, if you're struggling, don't be afraid to reach out to me. I can definitely provide some tips and some help. And then if there's a good portion of you guys, or really any of you that want me to do a video, if you have to retake it, hopefully you don't, I can go ahead and do that as well. So this week I'm going to be doing stroke, because that's what you guys did in class. So just starting off with what a stroke is, you should just understand kind of like the basic patho behind it. So as we already know, the brain needs a pretty constant supply of oxygen, glucose, other nutrients. And so if there's any sort of blockage, then that's going to result in brain cell death, which is going to lead to all these other clinical manifestations, side effects, you name it. So a stroke is also known as a CVA, a cerebral vascular attack, or a brain attack. But stroke is going to be the main name that you hear. Really quickly, before I go into the types of stroke, so there is something called a transient ischemic attack, or a TIA, which I'm sure you guys talked about a little bit, but this is basically a baby stroke. It's a warning sign. If you have a TIA, you're basically just waiting for the big one. And so it should be taken really seriously. It should be kind of like a wake-up call that, something needs to change. The thing with a TIA is there is acute infarction within the brain, so there is death, but your symptoms are going to resolve within 24 hours. This tends to be associated with ischemic stroke rather than hemorrhagic, which we're going to talk about the differences between the two, but the reason that it tends to occur more with ischemic stroke is because hemorrhagic stroke tends to be really sudden, whereas ischemic stroke tends to come from like underlying conditions like diabetes, hypertension. So it builds up over time, which gives you these chances to have TIAs, if that makes sense. So your symptoms will resolve in 24 hours. Sometimes they might even last less than 1 hour. You might not even really notice it. And then it can eventually lead to another stroke, and it might even just go on at that moment to become an ischemic stroke. So your signs and symptoms, just really any abnormal neurocranial abnormalities that you can detect. So like you might become confused, dizzy, you might have like a really bad migraine, floaters in your vision, balance issues, gait issues. Really just you're going to notice something's not right, and that's going to be your like precursor that there's something going on. Okay, so now I'm going to do a little bit about the two types of stroke. So I already mentioned, but you have ischemic stroke and you have hemorrhagic stroke. So the way that I remember Professor Schneider describing it to us is if you think of the arteries in your brain as like a hose, and if you have a kink that's going to block off, like if it's like a hose, like the water getting out, that's going to be your ischemic stroke. Whereas hemorrhagic is that hose is like overflowing. It's just like gushing. So hemorrhagic stroke is pretty straightforward. That's just going to be a burst blood vessel. Think hemorrhage. You're just going to be bleeding out in your brain. And so that's going to cause damage to the surrounding areas because it's going to have an increase in pressure. The number one cause that I have highlighted for this type of stroke is hypertension, so definitely understand that. And then one really important thing to know with this is your signs and symptoms are going to be usually pertaining to increased intracranial pressure. And I know that you guys haven't talked about that yet this unit. You will. But you should remember from Patho the whole like Mind Crush acronym about signs and symptoms of ICP. So the two biggest ones that you're going to see with a hemorrhagic stroke is you're going to have a really, really bad headache and really bad nausea and vomiting initially. It might not continue as time goes on, but initially those are going to be your two big symptoms. And then you're also going to have just like increased pressure. You might have a headache, things like that. LOC changes, hypertension. One thing that I am going to note here is the topic of permissive hypertension. So I'll talk a little bit more about this with ischemic stroke, but permissive hypertension is the idea that in certain situations, especially critical situations, physicians might actually let a person's high blood pressure, so their hypertension, run its course, because this tells the body that like, hey, there's an area of ischemia, we need to get blood flow to this area, we need to perfuse it. And so it can actually be beneficial, such as with ischemic stroke. But with hemorrhagic stroke, you never want to do permissive hypertension. You want to get that hypertension under control. You want to get that systolic under 160. The higher the blood pressure is and the longer it is, the more issues you're going to have, the more signs and symptoms you're going to have. The other thing that you don't want to do with hemorrhagic strokes is you don't want to use anticoagulants and antiplatelets. So like Coumadin, warfarin, heparin, those Lovenox, any of your anticoags, antiplatelets, those are automatically contraindicated if you have a hemorrhagic stroke, because if you think about it, those drugs are gonna like stop the clotting process, so they promote bleeding. And so if you give a patient that and they're having a hemorrhagic stroke, they're just going to continue to bleed. But yeah, that's really all I have for hemorrhagic stroke. So just understand what it is. Hypertension is the biggest cause. You get a really bad headache, really bad nausea, vomiting initially, and then you're going to have other ICP symptoms like LOC changes, hypertension, and you don't want to do permissive hypertension, and you don't want to use anticoags and antiplatelets. Also, this stroke is not as common, but it is more deadly. Okay, ischemic stroke is the other type of stroke. This is like the kink in the hose, and there's two types. So you have embolic and you have thrombotic. So hemorrhagic stroke we talked about is like the gushing of blood in the brain, so it increases the pressure, which is going to cause damage, it's going to cause death. Whereas ischemic stroke, there's inadequate blood flow to the brain, so there's something going on with those arteries that, you know, blood isn't going through, the cells aren't getting the oxygens, the nutrients that they need. And this could be from a partial occlusion, it could be from a complete occlusion, either one. But the difference with this is ischemic stroke is usually associated with underlying conditions. So hemorrhagic stroke, yes, hypertension is like the number one cause of that, but ischemic is usually from like atherosclerosis, I can never say that word, hypertension, and diabetes. Those are the three big ones, but the reason is because atherosclerosis is the big thing, and diabetes and hypertension tend to cause that, if that makes sense. So atherosclerosis, for those of you that might have forgot, is hardening and thickening of the arteries, and so this causes them to narrow, so blood flow can't get through, and so that can cause a thrombus or an embolus to form. Usually, like I said, this is seen with diabetes and hypertensive patients. So there's two types. You have embolic and thrombotic. So embolic, think away from the brain. So these are going to be patients that maybe have a DVT, they might have AFib or a PE, but basically the clot forms somewhere else and then it travels and it lodges itself in the brain, and so that causes the stroke. I used this story the first time I recorded this video. but I work on orthopedics at Barnes, and we had a patient who he had a stroke history, so that automatically increased his risk, but he ended up getting a DVT as a just like complication from his surgery, and he actually ended up stroking out, and they believe that it came from the DVT, that one of those clots dislodged and went to his brain. So that's why clot prevention is so important in a hospital, because like, yeah, DVT, like no one wants a DVT, but a DVT can become even worse and become a PE or become a stroke. So basically that clot, it's going to lodge in the brain, and that's going to cause infarction because the cells aren't going to get what they need. There's going to be edema, and this is usually very, very rapid. And so when you think of embolic stroke, you want to think rapid signs and symptoms. And this kind of makes sense if you think about it, because if you have a clot that just like suddenly lodges itself in your brain, like, yeah, it's going to be pretty sudden. So your patient might all of a sudden have LOC changes, they might have a headache, nausea, vomiting, gait differences, things like that. It could even be related to activity. So like your AFib patients, these patients are at risk for an embolic stroke, because if you remember, AFib is when your heart like doesn't contract right, and so the blood can pool in the ventricle, causing a clot, which can then go to your brain. So very rapid. The other thing you probably talked about with Professor Hamra is collateral circulation, which is how like your body can adapt in certain situations to try to get blood flow to where it needs to go. So that's why, like, I remember in Gerald's, we talked about how, like, older heart attack patients usually have a better chance of survival and recovery than younger ones, because they have all this collateral circulation built up from the years. But with an embolic stroke, you can't really use collateral circulation because it's so sudden. Your body doesn't have time to build up that circulation and get blood flow to where it needs to be. So it's very, very slim chances that you're going to have enough collateral circulation to keep things going. All right. So yeah, embolic stroke, just think away from the brain, then lodges in the brain. Think no collateral circulation usually, rapid, severe clinical manifestations, AFib, rheumatic heart disease, yeah, all those things. And then thrombotic stroke. So a thrombus, it's going to be when you have a area of the brain that forms a clot, but like it happens over time. And so when I first learned this, I remember I got kind of confused between the difference between thrombotic and embolic. So that's why when I started explaining it, I was like, when you hear embolus, think embolic stroke away from the brain, thrombotic stroke in the brain. And so that happens from atherosclerosis, which is that hardening and narrowing of the cerebral arteries. And so basically they become so narrow, and then the clot forms, there's a rupture, and that clot causes that damage. So thrombotic, it's usually from that atherosclerosis caused from hypertension and diabetes. This is the type of stroke that is more likely to be preceded by a TIA, because going back to what we talked about with TIAs, if you have hypertension, diabetes, and this atherosclerosis forming in your brain, there might be tiny little microemboli that form over time. And yeah, you might have clinical manifestations, you might have those TIAs, but over time, it's going to become so severe that you're going to eventually stroke out, if that makes sense. So since a thrombotic stroke is not usually as sudden, that means that your clinical manifestations are also not going to be as sudden and severe as with an embolic stroke, since it takes time to develop. So their LOC might not even change in the first 24 hours unless it impacts like your brainstem or a critical area of the brain. Now, obviously, if it's caused by like injury or something, that's a little bit different. But bottom line is your signs and symptoms are not going to be as severe in the beginning. And then within like 72 hours is when they'll start to increase, start to worsen as you get more edema, more death, and more damage. Okay, so that's all I have on the ischemic strokes. So just think partial or complete occlusion that causes cells to die, usually from atherosclerosis. Thrombotic is when you have a clot in the brain from atherosclerosis caused from either like hypertension, diabetes. Those are the biggest two causes that I have highlighted. Thrombotic stroke is a little bit more gradual, doesn't have as severe rapid signs and symptoms, and usually it takes like 72 hours to see changes. And then embolic, away from the brain, clot lodges in the brain, so like AFib, DVT, PE, rheumatic heart disease. It has more rapid, severe clinical manifestations initially. All right, so that is on the types of stroke. Really quickly, risk factors and prevention for stroke. So we'll talk a little more about prevention later, but risk factors for stroke are literally just like the same thing that y'all hear for every single disease process out there. But your biggest ones are hypertension and diabetes. 100%. Those are your biggest ones because they cause atherosclerosis. Other things would be just like an unhealthy lifestyle, obesity, smoking, obviously, previous stroke, like that one patient that I had talked about. Yeah, like I said, hypertension, diabetes, those are your big ones. One thing I would keep in mind with risk factors, I remember this was a practice question that we had, and it was that it gave like 4 different patients and asked who was most at risk for a stroke. So the more risk factors that a patient has, the more likely they are to have a stroke. And I know that sounds like pretty self-explanatory, but it can get kind of confusing in certain situations. So just think like if a patient is older, if they have diabetes or hypertension, anything like that, then they're at risk for having a stroke. As far as diagnostics go, so there's lots of different things that you can do to assess if a person is having a stroke. That's the first thing you want to identify. And then you want to identify the severity of the stroke and like what areas it's affecting. So as far as what to do to see if you have a stroke, so a CT scan is the first thing that you're going to do because that's going to see if there's a clot or a bleed. And then an MRI is the follow-up imaging. You're going to want to do a baseline neuro check. That's extremely important. I remember Dr. Schneider continuously saying that you want to have a baseline neuro check because sometimes, as I mentioned with like a thrombotic stroke, it can take a while for signs and symptoms to arise. And so you want to have that baseline so you know, okay, is this patient deteriorating or is this normal for them? Do they usually have a little bit of trouble remembering the date? Things like that. Heart tests like an echo, EKG, those sorts of things can help you see if there's like a heart abnormality that could be causing the stroke. If they have AFib, you automatically want to put them on tele. That's really, really important. That's like the heart monitoring that you'll see on patients. A carotid ultrasound goes for your carotids to see if you have plaque buildup. You can do a speech eval to see the extent of the damage, a lipid profile to see atherosclerosis, a glucose test to see diabetes. Pretty much you're just going to be doing a head to toe, maybe like zoning in on certain areas that you think are affected. We already talked about risk factors, we talked about the types of stroke. Okay, so now I'm going to move into what I feel like is a really big portion of stroke, and that is like the clinical manifestations and just like what is impacted by a stroke. And so there are so many things that can be impacted by a stroke, and no two stroke patients are going to have the same symptoms. Some people you might not even be able to tell, others might become extremely, extremely affected. So I apologize if this kind of like goes all over. There's just a lot. First thing that you need to know for this exam is your cranial nerves again. I'm not going to go over those because I feel like it's just a waste of time. It's just memorization. And I told you guys that when I was peer leading for health assessment. It's just memorization. Do the exact same thing that you did with that class and you'll be fine. You don't need to know like the sensory or motor like you did for Dr. Gurley, but you should know the nerve, the number, and just like a basic description of what it does. There was literally one question on our exam about this, and I'm pretty sure it was about the 12th cranial nerve, and it was like, your patient has a stroke that affected the 12th cranial nerve. Which of the following will you probably see? And it was trouble swallowing. That was the answer, because the 12th cranial nerve is your hypoglossal, so that controls tongue movements. That's literally what you need to do. It's that simple. Just do whatever works for you with health assessment. The other thing I'm not really going to go over is the areas of the brain. Once again, it's just memorization like you guys did with Dr. Gurley. So just go back, look at like what each lobe of the brain does, look at what Wernicke's area, Broca's area, what is the brainstem control, that's like your vital signs, and just understand that. If you guys have a lot of questions about it or just get like confused, then you can reach out to me and I can help explain it. So I would just go back, look at those areas of the brain, and then, reach out to me if you have any questions. But like with cranial nerves, it was literally one question, and I think it was the parietal lobe, maybe. So it was like, your patient has a cranial, or no, oh my goodness, it was your patient has a stroke that impacts this area of the brain. And it was a picture, and it had a hot spot on the parietal lobe. And so then you had to know it was the parietal lobe. And then you answered, and so your parietal lobe helps you with like sensation and like perception, and so that was the answer. Your cerebellum, that's another one to know. That's like your balance, coordination, and movement, that sort of thing. Okay, so aside from areas of the brain, cranial nerves, the other part that you need to understand with how a stroke can impact a patient is left side versus right side clinical manifestations. So you've probably heard like, oh, are you left brain or are you right brained before? And that's what this is talking about. So if you have a stroke on the left side of your brain, it's going to produce different manifestations than if it was your right. So overall, your left side of the brain tends to be more logistical and just more logic. That's going to be like the side that's in charge of analysis, sequencing, math, language, critical thinking, reasoning, words. So if you have a patient that is having trouble with speech, that automatically means that they're having a left-sided stroke. Another thing that's really, really important that I remember we talked about is that when you have a patient with a left-sided stroke, they are going to be aware of their deficits. And I don't remember exactly why. I don't think that's the important part. It's just that if they have a left side stroke, they're usually aware of what's going on. They're aware that they're having limitations and they're losing a decreased like function. And so that can lead to like anxiety, it can lead to depression, more mental effects. And they also might be really slow, cautious, take their time with performance because they understand what's going on and they understand that they have limitations. Your right side of the brain is the side that controls more creativity. So that's going to be like your intuition, music, arts, imagination, facial recognition, time, social concepts, attention span, emotion. And so that's going to be more of just like the arts, I think of. Two really big things that I remember, or actually three really big things I remember with right side is your right-sided stroke patients. These are going to be your patients that are like trying to get out of bed. They're going to be your high fall risk. They're going to try to do everything on their own because they have impaired judgment and safety issues. And so, like, these are the patients that need to be on bed alarms. They need to have somebody there when they're going to the bathroom and when they're ambulating because they're just going to try to do it. They're not going to care. So safety, impaired judgment, that's the first thing. Second thing is they tend to deny their problems or they minimize them. So like I talked about with left-sided brain, these patients are going to be the ones that are more aware of what's going on, and so they're more likely to take it slow and to ask for help. Whereas your right-sided, they're going to just be like, no, I can do it on my own. I don't need you. And they just keep going and they do whatever they want. And so they might refuse help. They might not seek help. They might not show up to their appointments. They might, stop communicating with family that's trying to help them. And so these are your patients that you have to be more concerned about, like complications. Are they going to heal? Are they going to get back to doing what they want to do? Because they're just blowing everything off. And then the other thing is that these are your patients that are more prone to emotional lability. So having involuntary outbursts of emotion. So they might just get really, really frustrated. They might become angry. They might start crying. They're just going to be all over the place. So that's something to keep in mind. There's a really good page in the Purple MedSurg ATI book that has like right side versus left-sided. And really quick tangent, if you guys don't use that book or you haven't used ATI books before, I would really recommend adding it to your study regimen. I never really used ATI before probably term 3, but term 4, I made it my mission I read every single chapter that we did for adult health. It was actually like I would do it right before I went to bed, but I'm not saying you need to memorize it, live by ATI, but it can just help provide a nice like overall just like overarching, give you the key points. And honestly, with Dr. Schneider, I feel like a lot of his lectures line up really, really well with ATI, which I know is not always the case. So I would recommend, if you don't have that purple book, using the online one. And if you have it, dig it out, get the dust off it, and try using it. The other thing with right versus left side that I think is really important to know, I have as highlighted, is that the manifestations of a stroke, they do not differ depending on if it's like ischemic or hemorrhagic. It just depends on the side of the brain. So that's why we choose to look at, okay, what are the signs and symptoms of a left-sided brain attack, whereas what are the symptoms of a right side? Because ischemic and hemorrhagic, it's just there's too many similarities. You can't really like split those apart, if that makes sense. The other thing that I forgot to mention is how if you have a left-sided stroke, that means that you're going to have issues on the right side of your body because the left side controls your right side. And if you have a right-sided stroke, you're going to have issues on the left side of your body. That hemiplegia, I can't say that one. So I'm sure you guys know what I'm talking about because you've probably heard it before. Other things that I feel like we might not have talked about that are manifestations. Just overall, you're going to have LOC changes, disorientation, memory impairment. That's pretty self-explanatory. Impaired mobility, altered gait. If you have, so I think I mentioned this with the areas of the brain spiel, but if you have a brainstem stroke, that's like a super serious stroke, and it's usually seen by alterations in vital signs, especially respiratory function, because the brainstem controls those vital signs and those vital functions of life. So if you have a patient that's having like breathing problems, they might have a brainstem stroke. Swallowing and gag reflex, that goes back to like your cranial nerves. They might have issues with self-care. Usually, I have this highlighted and I don't remember ever really talking about it, but sometimes with patients, you might see hyporeflexia initially. So, like, they don't have any muscle tone reflexes, and then over time, they become hyperreflexic. It doesn't go the other way. I don't know why I have that, but I have it highlighted. They might have seizures, visual changes, ataxia, which is what we measure on a sobriety test by doing finger to nose, but that's a loss of muscle control, coordinated movement. So that's why patients with strokes, they might have issues like buttoning buttons on their shirts. They might not be able to like brush their teeth, things like that. And then apraxia, they might not be able to perform learned tasks on demand. So anything they had to learn to do, they're probably not going to be able to do. Like if you ask them to tie their shoes, they're probably not going to be able to do that. Visual changes, going back to that, there's homogamous and hemi. I don't know how to say those words. I'm terrible at pronunciation if you guys haven't figured out, but there's a type of visual disturbance where it's hemi, which means that it's like both sides of the affected eye, and then there's homo, which is like the single part of the affected eye. So I think I might have gotten those back, or actually no, I think it has something to do with how it's like your field of vision and then how it pertains to. Okay, I'm just going to stop explaining it because I honestly am not 100% sure. I know ATI mentions that, so I would just kind of read over that. I don't remember being a test question on it, but might be a term to be familiar with, so that way if you see it, you know that that's a visual disturbance. Okay, so now I am going to kind of go into some stuff about like nursing interventions and how they pertain to manifestations. I have a little bit more time than I did with the first one because I didn't talk about. So, the first time that I recorded this, I included medications, but I actually ended up putting that in part 2 of this review. So, part 2 of this review is like medications, and then like nursing interventions as well. So, we're kind of wrapping up here. Okay, so for dysphagia screening, all stroke patients, whether they have a confirmed stroke or they're presumed to maybe have a stroke, they have to get screened in the ER for dysphagia. Have to. If they fail it, they are kept NPO. They cannot have anything by mouth until they are evaluated by a speech and language pathologist. And this is really, really important because with stroke patients, there's lots of medications that we might be throwing at them. And so if they are NPO, they might not be able to get their meds by mouth. So like, for instance, and I remember there being something about this, if they fail their dysphagia screening, then they might have to get aspirin rectally in the ER if they're NPO rather than by mouth. Something like that. So that's dysphagia. So just, looking at safe swallowing, a huge part of this exam, or not this exam, but this topic is education. And Dr. Schneider might have told you guys that. So like if a patient is on some sort of dysphagia monitoring, they're going to have signs in their room. So like I've had patients that just as they've got older, they can't swallow properly, so they're on a modified diet or like a safe swallow diet. So they might have to have thickening packets added to their food. They might have to be like completely 90 degrees. They might even need a feeder. So like they might lose that ability to feed themselves. They might need more water with their food. Those are just some examples of nursing interventions that you guys should be thinking about for a patient that has dysphagia. But bottom line is you don't want them. And I had a patient actually last week that he wasn't even allowed to take sips of water because it would just stay in his throat and he would like aspirate. So that might even be a case. Another thing about manifestations is the Glasgow Coma Scale, which I'm sure you guys remember from Patho, but this is one of those screenings. It looks at eye opening, motor response, and verbal response. Those are the three things. The top score is a 15, but if it's below 13, then you're thinking like, okay, there's an issue. If it's less than 8, you got to intubate. I always remember that because that's usually like a severe problem. So this looks at things like, is their tongue, or no, that's part of a different screening, sorry. So this one looks at like, how's their verbal response? Do they spontaneously open their eyes? Do they open it to sound? Like things like that. So for communication problems, so dysphagia is the swallowing issue. Aphasia is just like an overarching communication issue. There are so many different terms for aphasia, y'all. I had so many issues trying to keep all these straight until I realized that they kind of just all mean the same thing. So I know I told you to go know the different areas of the brain, but just really quickly, the Broca's area is in the frontal lobe, and that is responsible for producing speech. And then your Wernicke's area is in the temporal lobe, and that is responsible for like understanding speech, interpreting it. So if you have receptive aphasia, that means you can't understand it. You can't understand speech. You can still produce it to some degree, but you can't understand it. You're not going to create meaning. So that would be receptive. It would be fluent because you can produce speech. It's just not going to make sense. And then it's Wernicke's. So those are all three terms that you might hear that like go together. So receptive aphasia, Wernicke's aphasia, and fluent aphasia. On the other side, expressive aphasia means that you can't express your speech. So if you remember Broca's, that's in charge of producing speech. And then non-fluent means that you have a limited ability to produce speech. So expressive, non-fluent, and Broca, those all three go together in terms of speech. And remember that the left hemisphere is dominant for speech and language. So if you have any sort of aphasia, then that demonstrates that there's a left-sided stroke going on. Most of the time aphasia, it's a mix. It's not going to be just like clear-cut one type. And so I think that's really important to keep in mind. And if you have a massive stroke, it can result in global aphasia, where pretty much just like all communication function is lost. As far as nursing interventions and education for communication issues, you want to be a patient advocate and you want to find ways that you can communicate with them and help them to communicate with their families. So you might have to use a picture board, you might have to write things out for them. You might have to ask yes or no questions, keep simple, slow, natural speech, offer options, give them more time to respond. But you don't want to speak for them. You don't want to ignore them. You don't want to talk down to them. Just kind of like common sense things. We already talked about how there can be emotional issues on both sides. So patients that have a left-sided stroke, those are your safety concerns, not safety concerns. Your left-sided is the depression and anxiety, higher mental, higher chance of having a mental effect from a stroke. So that's really important to keep in mind. You want to make sure that you refer those patients to the resources that they need. Allow them time to talk if they're able to. Whereas your right-sided, those are your safety issues. Those are your patients that are going to have outbursts. One thing that's important to teach the family is how you can use distraction to help them with emotional outburst. Patients may also have issues with urinary and bowel elimination, but one point that I have highlighted is how usually this is temporary. especially if if the stroke only affects one hemisphere of the brain. If it affects both, then there's a chance that it might not come back, but if you have a stroke only affecting one side, the prognosis for normal bladder and bowel function is excellent. It's great. Constipation is the biggest GI issue, so you might think of, things that go along with that. So you could increase fiber in their diet if you're able to, increase movement if you're able to, increase fluids, maintain fluids if you're able to. And then you also want to think about the medications that you could use for constipation. And I think I mentioned this in the second part of the review, but one of the questions on my exam for this test, that didn't make any sense. One of the questions that was on my exam for this unit was a matching question. So it gave 4 medications that pertain to stroke and like clinical manifestations, and you had to match them. And I remember one of them being about Colace, which Colace is a stool softener. It helps you have bowel movements. So like think about Colace, think about Miralax, magnesium, those sorts of things. We already talked about diagnostics. And then I talk about TPA, drug therapy, all of that in the second part. I might have talked about this in the second part as well, but I'll just go ahead and talk about it because it kind of goes into what we just talked about. And that is just like preventative care and nurse management for education purposes. So the biggest thing is you want to teach prevention with your patients. So you want to help them have a healthy diet, control their weight, regular exercise, limit alcohol, stop smoking, and they should have like yearly visits to their primary physician to make sure that they don't have any like sudden like development of diabetes or hypertension, and if they do have diabetes or hypertension, to make sure that it's controlled. Sorry, I'm just looking through. Patients might even have to go to rehab. So I know Dr. Schneider had a slide for us on the different types of rehab. I don't remember there being anything on the exam about that, but just understand that patients might have to go to a different type of facility based on their needs. So like, for instance, in acute care, rehab hospital is the most demanding, and that requires several hours a day for patients. Like they are getting 24-hour services, and it's usually in a hospital, whereas like a long-term care facility, they provide only maybe like an hour of treatment a day, and usually like patients are able to still do things on their own. You should also understand, if you don't already, just like the different terms for a rehabilitation team. So like a psychiatrist, what do they do? What does PT do? So PT focuses on strengthening muscles, whereas OT helps with like ADLs and daily activities. So they're the ones that are going to help you get dressed. They're going to help you brush your teeth. Like I said, I work on an orthopedic floor, so I deal with PT and OT all the time, and I have to explain this to patients all the time. But OT, they're the ones that are going to help you just figure out like more lifestyle related changes. So like if they need to use a grabber to get things from the floor, or get things from like a bedside table if they don't have the strength, whereas PT is going to help them so that they're able to walk. They also might need a social worker if they have to figure out like where they're going, rehab, living, those sorts of things. Speech and language pathologist for swallowing, gag reflex issues, that sort of thing. And yeah, so I think that's all I'm gonna have for this part of the review, because like I said, in the second part I do like all the medication stuff, and yeah, so That's pretty much it. But as I think I mentioned in the second one, if you guys have any questions, if you don't understand something, it doesn't make sense. I think I probably confused you guys on like the hemorrho, the eye thing I was trying to talk about. Don't worry about it. Use ATI if you're able to, and I think you guys will be fine. But like I said, don't hesitate to reach out to me if you have any questions.